Good afternoon. For those of you who don't know me, my name is Bill Brown, and I chair the InfoHealth series. I just want to remind the viewing audience, and now we have YouTube as well as Cogeco, something about the program. This program is now in its 13th year, which is quite remarkable. And it's really a partnership between the Niagara-on-the-Lake Library, the Niagara-on-the-Lake community, the local family health team, Cogeco, the cable network here, and the Michael DeGroot School of Medicine, the Niagara division. So that's quite a team, and it's worked very, very well. Before I get into what we're going to talk about today, which is the family health team, I just want to say something about the upcoming programs because, first of all, on InfoHealth, the next one in November is on AI, or artificial intelligence, and medicine. That's a huge subject now in healthcare, and I think that will be very well presented. So that's one to catch. Then there's one by Professor Larry Chambers, who I met, and you may know him, right? Because he's the head of research in the Niagara area, but he's a very interesting person. But anyway, he's talking about an aging population and long-term care. And I gather he's been spending a fair bit of time visiting long-term care facilities in the Niagara Peninsula. So he's actually doing the footwork for that. So that should be very interesting. So that'll take us to the end of the year, and then we run on for another 6 months. The other thing that's happening is the Nobel series. We've had one series last year, which I think was pretty successful. And the template is an obvious one, the Nobel Prizes. There are 6 of them. So there are 6 sessions. Last year we strung them out, so one was presented monthly. This year we're looking at the possibility of doing it weekly, which would really fit in with kind of the excitement and the interest, the public interest in the Nobel Prizes. So the physics and medicine and chemistry prizes, which have all been announced already, they would be the first 3 weeks in November on a Tuesday, I hope, at the same time, but not when InfoHealth is Wednesday, this is Tuesday. So we'll see, because that doesn't include obviously the Peace Prize, the Economics Prize, or the Literature Prize. So, well, let's get on to this one. The subject today is the family health team, and the group of medical students now in their 2nd year now at McMaster in the Niagara campus really did a beautiful job in June of introducing what is a complex subject, and there's some concern about where it's going, where it's going to find its feet, and issues like funding and direction, that kind of thing. And I think you're probably going to deal with that today. So it is the same successful team that we had the last time. So I'm just going to introduce one after the other, and so that you're reminded. Yes, I bet Bethina over here. Yeah. George Hugh and Hannah Kearney. Yeah, and Michelle Murdoch. I'm hoping they're all on YouTube. Well, by the way, I forgot to mention this is the first time we've been on YouTube. Yeah, so that's a huge plus. So I'm not going to say anything. Who's starting this off?
I'm starting first.
All right. Okay. This is a self-regulating body, which is more than I am.
Okay, well, thank you everyone for joining us again. Welcome back to our 2nd installment of our family health team presentations. Today, we will be discussing the roles of interdisciplinary healthcare providers in family health teams. Here we go. So in today's presentation, we will briefly summarize our last presentation on family health teams. then move on to describing the roles of some of the members of the family health team. We're going to try to elucidate their main differences, clarify some common misunderstandings regarding these roles, and finally we will walk through a real-life example of what your interaction with the family health team could look like using a memory clinic to illustrate our point. So in our last presentations, we explained that family health teams are composed of a number of healthcare professionals offering an interdisciplinary approach to care. We also discussed some of the ways in which physicians are paid or remunerated in the province of Ontario, and how this can be reflected in your interactions with healthcare. And finally, we discussed the future of the family health team and some of the uncertainty that exists regarding the future workings of the new Conservative government's Ontario health teams. As we mentioned in our previous presentation, a visit to your family health team can include so much more than just an appointment with your family doctor. There are numerous groups and allied health professionals available for a variety of different resources and services. So to refresh our memories, here are some of the examples of the services offered at a variety of family health teams in the Niagara region. For example, we have asthma education and support, mental health workers, memory clinics, foot and wound care clinics, as well as nutrition guidance and much, much more. Last time, we also spoke about the way in which physicians are paid in Ontario. Some doctors are paid by a fee-for-service model in which there's a predetermined amount of funding to be made for a particular service provided. Others are paid on a capitation-based model in which physicians are paid per patient on their roster. And others are paid a fixed yearly income with a salary model. In addition, in any of these models, there is additional room for extra targeted payments or bonuses, and some practitioners are actually paid using a blended or mixed model of any of these three. And finally, we also spoke last time about the future of primary care in Ontario with the new Conservative government's proposal for Ontario health teams. At this time, the implications of creating Ontario health teams, particularly their effect on the family health team, is still unclear. Right, now I'll introduce Hannah.
Hi everyone, so I'm just going to go through a couple people that you might see when you go to your family health team. So I'm going to start off with physicians and physician assistants. So physicians are also known as medical doctors or MDs, and so in order to become a physician, most schools require that you have some element of undergraduate education. So in most cases, that's at least 2 or 3 years of a post-secondary bachelor's degree. And then after doing that, you would gain admission to medical school. So medical schools in Canada are, for the majority, 4 years long, with the exception of McMaster and Calgary, which are 3-year programs because we run through the summer. After completing medical school, physicians then go on to complete residency. So residency is just the area of medicine that you choose to specialize in. So the shortest residency program would be 2 years long for family medicine and up to 6 or 7 years for something like neurosurgery. And that's a mandatory part of our training. After that, there is an optional component where you could do a fellowship. So an example of a fellowship would be a family doctor who completes their 2-year residency program, but then goes on to complete a 1-year program in a more like specialized area. So for example, you could do something in sports medicine, you could do something in women's health or low risk obstetrics. In terms of scope of practice, physicians can diagnose, prescribe, and they can also complete procedures and operations depending on what specialty they go into. In all cases, the physician is the most responsible provider, or the MRP, meaning that any of their actions they're legally liable for. We also have physician assistants. So physician assistants are quite popular in the United States, and they've made their way into Canada as well. Sometimes you might see a PA at your family clinic or at the hospital. So the difference between a physician and a physician assistant is that a physician assistant also completes an undergraduate degree, but then instead of going to medical school, they go to physician assistant school. So in Ontario, PA school is a bachelor's degree, and then in Manitoba, it's a master's degree. So in terms of their scope of practice, they work directly with a physician who supervises them. So depending on their physician supervisor, they can negotiate what tasks they would be allowed to complete. and they're not considered independent practitioners. So they themselves are not the MRP. The physician that they're working with is legally liable for their actions. So if we just look here, I've got a kind of a chart. So you can see that the education for a physician is much longer in length. So although they both require at least 2 or 3 years of an undergraduate degree, the shortest possible time that you could be in medical school and residency is 5 years, whereas the PA school is only 2 years long. After that, physicians have the option to complete a fellowship, whereas physician assistants do not. They both operate using the CanMeds framework, which has 7 roles. So those are professional, scholar, health advocate, communicator, collaborator, leader, and medical expert. And then their scope of practice is different. So whereas the physician is the most responsible provider, the physician assistant is working as a physician extender and working in collaboration with the physician to practice. There are also different kinds of nurses that you might see at the hospital or at your family medicine clinic. The first of which are RPNs. So registered practical nurses complete a post-secondary school college program. So this would be after high school. And their scope of practice, they do get to practice autonomously, and they can do things like patient care, administer medication, and perform small procedures like wound care. However, because their program is condensed, they can't do things like work with complex patients. So for example, if you're in the ICU or the intensive care unit, it's most likely that an RPN would not be working with you unless they were under the supervision of someone like an RN. RNs, or registered nurses, are people who've completed a 4-year Bachelor's of Science in Nursing degree. So instead of it being a college diploma, they've gone to university for 4 years. And in this case, their scope and their role is quite similar to that of an RPN, the only difference being that they can practice anywhere. So they can practice in the intensive care unit, they can practice in surgical settings, as well as medicine settings as well. And then finally, you can also have a nurse practitioner. So sometimes if you go to your family medicine clinic, you might end up seeing the nurse practitioner instead of seeing your family doctor. So a nurse practitioner is someone who has a Bachelor's of Science in Nursing degree. So that's a 4-year university degree. Then they've worked as a nurse for 2 to 3 years before applying to this program. So it's a master's in nurse practitioning, and they also get to specialize in a specific area. So some choose to practice in adult or pediatric healthcare, but you can also practice in anesthesia or primary healthcare as well. And so an NP is an independent practitioner, but they also have extended duties. So versus an NP and an RPN, where it just depends on the complexity of the patient, an NP can actually practice, they can prescribe, and they can diagnose and do some procedures as well. So they have a little bit more authority than an RN. So if you look here, RPNs and RNs, and I guess NPs as well, everyone that needs to finish high school, but then the difference would be doing a college diploma, a university degree, and then doing a university degree and a master's. And so as you kind of go from an RPN to an NP has a lot more power in terms of prescribing, ordering, and interpreting tests, which is one of the reasons that you might see them sometimes in your family medicine clinic instead of the doctor, depending on what your need is. And then just looking between physician assistants and nurse practitioners, because this is something that confused me, they do have very similar abilities. The only difference really is that with a physician assistant, they are never considered the most responsible provider. So they're working in collaboration with a doctor, whereas a nurse practitioner is working through under their own license, so they're legally liable for anything that they do. But in terms of general kind of day-to-day things, they can both do things like ordering and interpreting tests. NPs can prescribe, and depending on the physician assistant's agreement with their doctor, they may be able to prescribe certain things. But the nurse practitioner is really operating as an autonomous practitioner, whereas the physician assistant is working in collaboration with their supervising physician. Okay, so that's it for me. We're going to talk about some of the other allied health people that you might encounter when you go to the hospital or when you go to the family med clinic now.
Yeah, so I'm just going to talk a little bit about some of the various types of support staff and allied health that you would typically see at your family health team. So we'll start off with the chiropodists. So they are professionals in foot care. They used to be called podiatrists until their title in Ontario changed in 1993. So as such, anyone in Ontario who refers to themselves as a podiatrist either graduated before 1993 or were trained elsewhere, most likely the US. So they are certified with a Doctor of Podiatric Medicine degree, which is a 4-year degree, a bachelor's degree. And they are not MDs. They can treat numerous diseases of the feet, can prescribe medications and orthotics, and can also perform some minor surgeries on the foot. Next is the occupational therapist. So they are also licensed healthcare professionals. They specialize in empowering patients to participate and engage in their activities of daily living. But because everyone is unique and everyone has different activities that they go through on a daily basis, this means that occupational therapists have to tailor their treatment plan and their therapy to the specific patient's needs. So daily activities can include leisurely activities like gardening or productive activities like getting them back to school or work. It can also include things like self-care, like showering or eating or general hygiene. Their scope of practice can include providing personal, workplace, or home functional assessments. So they visit the workplace or the home, and they assess the area for safety, risk of falling, things of that nature. And then they can provide recommendations in order to make their workplace home environment more safer. And they can finally also provide help in finding resources in the community that can help them also regain some of their function as well. Occupational therapists are not MDs, but they are certified as licensed occupational therapists after receiving a master's degree in occupational therapy, which is a 2-year program, direct entry from an undergraduate degree. They must also be registered by their provincial regulatory body, which in Ontario is the College of Occupational Therapists of Ontario. Next is a physiotherapist. So it's really easy, I guess, to mix up occupational therapy with physiotherapy because there is usually a lot of times they're lumped together, and so I guess it's important to sort of understand that physiotherapy really focuses on providing physical therapy to patients. So this can include things like strengthening the muscles, things like ultrasound, therapeutic ultrasound on the hands for ligament or tendon injuries, and also to help alleviate pain and provide comfort and help with things like balance. So while they do have a role to play in well-defined musculoskeletal problems like neck pain or back pain, they also have roles to play in helping patients get rehabilitated after suffering a stroke or a heart attack. So while occupational therapy has sort of a more holistic approach in trying to get them back to work or get them back to school or get them back to whatever their daily function is, physiotherapy has the emphasis on using physical therapy, exercise, and strengthening to sort of get them back up and running. Physiotherapists are not MDs, but they are certified as licensed physiotherapists, and they also receive a master's degree, a 2-year master's degree, which is a direct entry from an undergraduate degree. They must also be registered by their college, which is the College of Physiotherapists of Ontario. Next is the respiratory therapist. So, like the name implies, they help patients who have problems with diseases like COPD, asthma, basically problems with the lungs, cardiopulmonary disorders. So their scope of practice can include things like providing education on how to use puffers, or helping with quitting smoking, chemical strategy for smoking cessation. And they can also assist in the diagnosis of a respiratory disorder, of like a breathing problem, through what's called spirometry or like breathing tests. So they can also help conduct those as well. So respiratory therapists are not MDs, but they are certified as registered respiratory therapists after receiving an advanced diploma in respiratory therapy, which is a 3-year college program, and it's direct entry from high school. They must also be registered with their provincial regulatory body, which is the College of Respiratory Therapists of Ontario. Okay, moving on to sort of mental health support that you can find in a family health team. So we'll start with social workers. So these are also registered healthcare professionals. They can help patients by performing psychosocial assessments. They can provide guidance with respect to coping or grief management, as well as navigating the medical system and long-term care support. Social workers are not MDs, but they are certified as registered social workers, and they have to go through a 4-year undergraduate program in social work, and that's a direct entry from high school. They must also be licensed by certified by their regulatory body, which is the College of Social Workers and Social Service Workers. Next, you may also encounter a psychologist. So a psychologist is actually a PhD, they're called clinical psychologists, and they're PhDs. So their education is after a master's degree or potentially even an undergraduate degree, like directly from an undergraduate degree. And the PhD itself can take maybe 5 to 8 years. They are basically experts in brain behavior and mental health, and they have very significant clinical overlap with psychiatrists. The key difference is that because they're not medical doctors, they don't go through the medical school process, they cannot prescribe medications. And they're also governed by a regulatory body, which is the College of Psychologists of Ontario. Finally, we have the psychiatrist. So the psychiatrist is trained through the medical system. So they go through medical school, they have residency, and then like Hannah was saying earlier, they can also have an optional fellowship as well. And their scope of practice is on also diagnosing and managing and evaluating various mental health disorders, illnesses, or issues that individuals come with, like bipolar disorder, anxiety, depression, and sort of treating those types of illnesses. And that's because psychiatrists are trained as medical doctors, they are governed by the same college that would govern your family doctor, which is the College of Physicians and Surgeons of Ontario. Okay, so just a brief review then of just comparing the main differences between these three groups of healthcare workers. So social workers are probably what you're going to see more for ongoing counseling. They can help you with ongoing counseling and helping you with like common mental health conditions. But then you can move to a psychologist if you have to, let's say, help with the management and diagnosis of like complex as well as common mental health conditions. But depending on the practice, they may or may not be able to provide you with that ongoing counseling support. And then finally, a psychiatrist. They can help with the diagnosis and management as well of common and complex conditions. They can also prescribe medications and therapies. But in most cases, though, they are not in the position that they can provide ongoing counseling support like a social worker. So it really depends on the needs of your particular needs. You would end up seeing one of these three mental health workers. Okay. All right, so I'm going to bring George up, who's going to talk to you about pharmacists.
Thank you, Azad. So now I'm just going to talk about some of the more, some of the other healthcare professionals that you may see in a family health team. So the first one that I wanted to talk to you guys about was a pharmacist. So a pharmacist is someone who specializes in dispensing drugs, creating medications, changing regimens, and giving you information on how to take your medications. To become a pharmacist, you have to do a undergraduate degree, so 3 or 4 years, followed by a 4-year PharmD degree at a pharmacy school. So in Ontario, we have one in Toronto, as well as others across the country as well. And the main scope of practice for pharmacists is that they're able to give vaccines, they can change certain regimens in your medications, as well as they can initiate smoking cessation medications as well. So if you want to, if you are someone who smokes and you want to think about quitting, that is someone that you can talk to as well. And pending new legislation in Ontario, they are also will be able to start prescribing certain medications for minor ailments. So those would be ailments that, for instance, you don't need to follow up with afterwards, you don't need any lab tests, you don't need any blood work, things that can be treated right there within the pharmacist's office. So here I just wanted to show you a little bit about how the scope of practice for pharmacists has changed and developed, as well as how it varies province to province. So you can see how the different things that pharmacists can do, specifically back in 2005, as well as currently in 2016. So as you can see, over the years, the scope of practice for pharmacists has expanded, and it is continuing to change as well. One of the things that you can see specifically here is that depending on which province that you're in, the scope of practice will be different. So for instance, the legislation that I mentioned earlier that allows pharmacists to prescribe, that's currently ongoing, but in a province like Nova Scotia, that's a piece of legislation that's already passed, and pharmacists can already prescribe medications for those minor ailments already. Next up, we have the medical office assistant. So oftentimes when you go see a doctor or a family doctor or at another clinic, you'll encounter a medical office assistant. So this will be like the first person that you encounter when you walk in. So medical office assistance is a diploma or certificate program depending on where you do your training, usually about a year or so. And it basically teaches you the basics about OHIP billing, about funding, and basically some of the basics around the anatomy, physiology that may be required in the setting that you work with. So in addition to working in a family doctor office, they can also work in other places like a hospital, long-term care home, a community center, etc. And they're responsible for all the office duties, taking care of all the admin work, as well as billing, charting, and other responsibilities as delegated by the MRP or the most responsible physician. And next we wanted to talk a little bit about dietitians. So to become a dietitian, it is a 4-year RD degree or registered dietitian degree that you can apply to after high school. So you don't need to do a bachelor's degree before that. And to consider yourself a registered dietitian or a dietitian, you need to have gone through the 4-year degree as well as become a member of the College of Dietitians of Ontario. And once you graduate, you can start working as a dietitian, either with a family health team or with any other teams in hospitals in a variety of locations as well. And the main services that a dietitian will be able to provide is advice on nutrition, advice on your diet if you have chronic long-term illness such as, for instance, diabetes. If you have high blood pressure, they can always give you advice on, for instance, like food that you can eat, food that maybe you should stay away from, and they're a great resource for that. And also, if you don't have any long-term conditions, you can still go see a dietitian to see how you can optimize your diet to kind of control some of the risk factors so that you don't get some of those conditions that we were talking about. And one of the things that we wanted to do is kind of differentiate between dietitian as well as nutritionist, because sometimes people think that they're interchangeable. So in Ontario, the term dietitian is a protected title. Only people who have gone through the 4-year degree and have had the training and practice up to the standard and the guidelines received by the College of Dietitians of Ontario are able to use the term dietitian. On the other hand, nutritionist in Ontario is not a protected title. Anyone who wants to give advice or wants to try and teach people about diet or food or anything like that can call himself a nutritionist. There's no degree necessary, and they don't necessarily have to practice to a certain standard. However, that does differ depending on which province you're in. In some provinces, they're both protected titles. In some provinces, it's the nutritionist that's the protected title, so that it would be flipped around. But in Ontario, this is how these two terms work for our province. So now we're just going to go through a real world example of the types of people that you may encounter when you enter a family doctor's office.
Great. Thank you. So now that we've heard from my colleagues about all the different team members that you might encounter, we thought it would be a good idea to walk through a real world example with you if you were to step into your family health team's memory clinic, those types of people that you might encounter. All right. So presumably the first person that you would interface with would be the medical office assistant. This is the person who would likely be picking up the phone when you call to make your appointment, and this is the person that would greet you upon arrival, notice that you're there, and let you know that the doctor will be with you shortly. Then you might see a registered nurse first, and the registered nurse might take your blood pressure, your heart rate, your temperature, your vital signs, and get you all set to see your family doctor. They may also take a medical history, ask you about what's been going on in advance of the doctor coming into the room. Then, most likely, your family doctor, or maybe a physician assistant, or maybe a nurse practitioner, whomever is seeing you that day, will come and see you for your actual visit and checkup. They can prescribe medications that you might need or make referrals for you. Your registered nurse may also come and visit you after the physician has been in and can provide you with education about some new medications that you're taking, any changes. Nurses are really excellent for providing patient education in that sense. And then if you're part of a memory clinic, you might also have the opportunity to visit with an occupational therapist. An occupational therapist can help you come up with some strategies to help you complete tasks of daily living like dressing, hygiene, toileting, mobility, and cooking more independently. If your team happened to have a psychologist or a psychotherapist like a social worker, they might be able to support you with any mental health concerns that you have, with coping, and with family support. A social worker in particular can also connect you with the appropriate authorities for financial support, home care, transportation, and any other community services that they think that you might qualify for or benefit from. And your pharmacist would be familiar with your health conditions and can provide you with new medications that you've been prescribed, as well as some education about how to best take them, some strategies for remembering how to take your medication as well. And finally, if a dietitian was available at your family health team, they might be able to help you create healthy meal plans and solutions to keep your diet and feeding habits independent and balanced. And with that, we thank you so much for your attention, and we welcome any questions that you may have about our presentation. Thank you so much.
So, many thanks to Michelle, Hannah, George, Saad. It's kind of a menu of what on the books happens, but it's probably not everyone's experience, I think. And furthermore, the model is changing, right? I just got back from Thunder Bay Clinic, and there are 3 family health teams there that are entirely nurse practitioners. And I think there's a 4th one forming. And anyone who's lived or worked in the United States realizes that non-MDs can do a lot more south of the border. I guess one of the things one of the physicians in town several years ago got into this conversation about what does the nurse practitioner do and what does the family physician do, and what are the relative roles of those two? And the response was, well, they don't know what they don't know. But the same is also true, I think, of family physicians and physicians in general. We don't know what we don't know either. And so I think that all of these, it's become when I was looking at those charts and all of the players, I just saw the dollar signs going up for just how expensive these clinics and perhaps how unsustainable they might be going ahead. Now, not every clinic has all of those players, but even if they had half of the people that you described, it's a lot, and the numbers increase. So that's just, and then one last thing, and then I'll audience can chip in. One of the concerns that I've always had, and it's true of specialists as well, is the whole communication business. Who talks to who about what? I sometimes get the feeling that the players don't actually talk to one another. It may enter the electronic record these days, but as far as actually talking about the team, a group of 3 or 4 people actually getting together and talking about a patient and sorting their way through it, that's unusual. And it's the pressure of time, I think. And also the control of the computer. People, I just know that, for example, the consulting time in the US is probably the same here now. It used to be say 40 to 60 minutes for a full consultation. And if it was a return visit, that might be 20 to 30 minutes. That's about a third now. And a lot of that time is looking at the screen. So there's a communication problem with patient, between the patient and the provider, and also less time to get this stuff kind of done in. And a huge pressure, especially south of the border, but here too, to get people through the system. So all of us have a story to tell and thoughts. Let's just open it up to, after all of you are members of family health teams. All of you have had experiences. Some of you have had experiences south of the border, as well as in Canada. Some of you have had experiences in the UK and other places. So you do have experience that's worth hearing, and so I'd be very interested in what you have to ask our speakers. And any thoughts? No? You mean you're totally satisfied? All right.
I have a question.
Neil, there we go.
Are you talking to me?
Yes.
Okay. What is a private clinic? I was referred to a wound clinic yesterday for a wound on my right leg. And I said to her, while she was dressing my wound, do you have any non-stick pads, so that nothing sticks? And she said, oh, we can't afford those, we're a private clinic. And I was dumbfounded. I said, they're only 50 cents each at the store, and you can probably get them cheaper. Well, she said, we're a private clinic, we can't afford those. So I just didn't say anything more. That was it. What's a
Michelle or
private
Aaron?
clinic?
Michael, do you want to comment on that? Because there's been a proliferation of private services, right? And things that aren't covered by OHIP in some cases, right? Is there anything you wanted to add? I mean, those are extra players in the healthcare system that weren't there 10 to 15, 20 years ago. And by the way, while we were talking about psychiatry, try and find one.
Well, yeah, how many
Try
are
and
there?
find a psychiatrist in the Niagara area. That's been a real problem.
It is.
So it sounds as if they're accessible, well, they're not.
But what is a private clinic? What is
They're
it?
private.
I mean, do they get paid by OHIP or what?
Some of the services, if they're billable services, yes, but some of their services are not.
What makes them private then?
Well, they're paying their own secretaries. And,
Oh, I see,
yeah.
okay.
And the space they rent. So,
unless they're in a hospital or a clinic, or is that a private?
well, some private services, and I'm thinking, yeah, well, I can certainly speak directly to this from Northwestern Ontario. Some of them are embedded in the hospital, and they rent the space from the hospital, and they provide these kind of private services. So we've seen this kind of nibbling away at care, or outsourcing it to private sources, so the province doesn't have to pay. Right? And these are extra services. For example, if you're looking after MS patients, some of the services that they get are private. So that's an out-of-pocket expense for them that wouldn't have been there, say, 10 or 15 years ago.
But I didn't have to pay anything.
No, well, if the services are covered by OHIP, then you don't have to pay anything. Yes.
Could you ask, who referred her to the wound clinic? Was
Yes.
it under her family health team?
We have the experts from the
Yeah.
family health team here.
Like, was your family doctor referred you to the wound
The,
clinic?
the nurse practitioner.
Okay, so it sounds like a family health team, and they have that service. So like you said, when you go to this wound clinic, maybe it's an outsourced service.
Well, then they've referred me on to
Isn't that
CCAC.
illegal?
Yeah, chiropody is one, where sometimes you're paying, OHIP reimburses for some of that services, but that might be every 6 months, or every 9 months. But if you require that more frequently, then that may be a private service, and that's out of pocket. Anything you want to comment?
Just, we can all think of some examples. The way that publicly funded healthcare works in Canada and works in the province is that there's a certain number of services that are deemed to be, necessary globally that are provided by our publicly funded healthcare. So when you visit your family doctor, you don't have to pay for that visit, or if you go to the emergency department. But there are all things that we can think of that we have to pay out of pocket for, even though it might be nice to have it covered. For example, physiotherapy to a certain extent may or may not be covered. We have to pay for our prescriptions to a certain extent out of pocket. Other services, like you were mentioning, chiropodists or dietitians, depending on the circumstance, may have to be paid out of pocket. And so in that way, while our system is generally publicly funded, there are always aspects that are also privately funded where we ourselves have to put out the money for that.
Which wasn't there before.
Mm-hmm.
So it's a new expense in the system. Now we have Jordan Lukens here, who's the mentor for all of these students, and a senior and experienced person in the family health team, our family health team, the group. So Jordan might want to step in at some point, but I think these issues, looking at all of those players involved, it's got to be almost borders on total confusion for patients coming in sometimes about who's sorting out what when, and who's in control. Is it the family physician? Is the family physician the apex of the service? I think that was the intention originally when they came in. Am I right, Jordan? I think it was.
Yes. It's still the family physicians are still the owners of the chart and kind of quarterbacking the operation.
Literally, legally, the owners of the chart.
Well, they can. That's a technical question. They can assign those rights to an organization in some cases, but by and large, yes.
Okay.
Are all family health teams created equal?
Maybe this is a conversation. Is it best
Well, that's a very important question.
It gets to the question you were already having, because family health teams are funded by the government within a budget. And within those budgets, they have some discretion about what they spend money on, depending on the community. One community might decide that they have needs in one area and might invest it in wound care. Others might decide that they have more needs in mental health and might invest it in social work. So the budget has some fluidity to it. They have to make a case to the government why that service is necessary in their area. Because there's no new money flowing into family health teams, to get a new service is always at the expense of another service, right? So depending on your family health team, there may or may not be wound care available. They may or may not have to refer you out to a private clinic or CCAC for that. So no, not all family health teams are created equal. They have evolved over time. They're within the limits of their budgetary allotments from the government, and then made determinations over time about what services will best suit their community. So it depends what you mean by equal, but the easy answer is no. You will find very different variations.
And I don't blame the clients
Jordan,
coming
could you
frustrated.
come here, because I think it's important. You're the one with the experience.
Great job, guys, and they do a good job. Yeah, I learned some things from this presentation too, by the way. Don't tell them that.
Okay, but this whole issue of family health teams differ a lot, place to place, and sometimes they're minor, well, they're not minor irritants. So if you're at the cottage in the summer and something happens to you, and you go to the local family health team, I've certainly heard it happen more than once, that have said, no, you have to go home to your own family health team. We're not looking after you.
So family health teams are designed around a rostered patient practice, right? So what that means is that when you are become a rostered physician of your patient. They own you in the sense that it is their job and their role to manage your health care. But family health teams have never been established to accept walk-ins or patients outside of their practice. So that means, yes, if you're moving around in Ontario, you're essentially confined to walk-in clinics and ERs. Is really the only way to access service outside of your area. It's an interesting conversation because there's not as much fluidity in the healthcare system as you might think, especially for those who travel a lot because of work and other reasons as well. And there was more recently a move to even reinforce that, where physicians, where the government was actually proposing that patients would be assigned a healthcare provider and may not have a lot of choice in that. The physician may not have a lot of choice in that, and you may be assigned to someone based on your geographic location, whether or not you work in another place. So it's a very interesting topic of conversation, but family health teams were never designed to accept patients outside of their rostered patient practice, if that makes sense to you.
Excuse me, you say own you as a patient, is that 9 to 5 or is that 24/7?
That's 24/7.
Except when they don't, right? Like the clinic is closed after 5?
In every family health team, there will always be a physician on call.
Yeah.
So that doesn't mean that there's actually a clinic running, but there will always be a clinic on call. Depending on the size of the organization, they will be after-hours clinics, which are usually on the weekends or evenings. And depending on the size of the physician group, it determines how many call shifts they have to have per week. So most family health teams and the family or the physician associations that underlie them would have clinics running almost every evening and every weekend as well.
Are the family health teams, wrong word, but certified or regularly reassessed by the provincial government?
Yes, there's
For their services
Yeah,
that they
annual
provide?
reviews.
So there are standards and?
Yes, absolutely.
Okay.
And there's constant quality improvement measures that they have to meet and be assessed by.
How
Okay.
often, is it like Revenue Canada, they come and check your charts?
There's documentation that's submitted, there's multiple different types. There's quality improvement documentation that's submitted annually. There's annual reviews that are submitted, and justification for expenses and budgets.
So maybe we should have part 3 then. I think a lot of us are not understanding what happens after hours. People get upset. I know someone that works with a family health team, and she's a medical secretary, and they're just angry at her all the time because you can't fit her in. Like if people understood the process and if they educate them, do they have to educate them? I think the government, because they're the one that proposed these health teams.
Right. You know, it kind of comes back to your question about are all family health teams created equal? And it's not so much the family health teams, it's the family physician groups that underlie them they can't determine how often they do have call shifts. That's kind of predetermined. Our group, for instance, does more than we need to. But they do determine the underlying structure of how those teams, or how those clinics run. So for instance, if we are required to have a 3-hour after-hours clinic, some teams choose to cap that off, and once the 3 hours is booked, that's it, and then they go home. Others will choose to have that continue open. The physician will stay on until all patients that need to be seen are seen. There's some variation in how those clinics are run. You know, if that's an issue for you at your local physician group, that is a very reasonable thing, I think, to bring up. Because there's variance in terms of how accessible those clinics are, and there's variance in terms of whether those clinics are reserved specifically for urgent care only, so things that need to be seen the same day, you're sick, you've cut yourself, something like that, or whether those clinics can be pre-booked for routine stuff like regular checkups or medication renewals. So there's variance in how those after-hours clinics are used and what their purpose is. Because the only part that's really mandated is that they have to exist. Does that kind of answer your question? And then you kind of have to delve into the individual group and see how they are actually managing that and whether it's meeting the needs of the community.
But I think it is a real problem. That there's perception that there isn't 24/7 coverage. That was one of the mandates when these programs came out. It's written right in, right? It's clear. it's not like, for example, my son in Halifax, where his wife in gynecology and he's an ENT, they're clearly, they take turn. They end up going into the hospital to do whatever they have to do. That's the way it is, it's 24/7 coverage.
And there's always a physician on call for our team, who is accessible by phone for urgent issues. It's an interesting topic of conversation too, just in terms of how you would access their care if it were outside of clinic time, and I think that's part of what's underlying the question as well, and that's nuanced too. Because if there's not a clinic actually open and staffed, then there's no way for them to actually get you into a clinic if it is outside clinic hours. And house calls have actually had reduced funding just recently, just over 9 days ago. House calls are still covered for housebound patients, but if there's no clinic on a Sunday, for instance, and you needed your doctor to come and check on your kid with an ear infection, that would no longer be covered by OHIP. So there's some nuances there as well, and in terms of what's covered and what's possible. Yeah.
Do I understand you're the head of the Niagara Health Team?
I was the chair of the board for the Niagara North Family Health Team. My term finished in the summer, now past chair. And you can see the wrinkles falling off my face, right? Don't I look so much more relaxed?
Much after that.
Maybe you can tell me how many psychiatrists are on our family health team.
Yeah, it's a great question. So to answer that question, I'm going to back up a little bit and go back to the funding question, because we get our fixed budget, and psychiatrists, when they're part of a family health team, are contracted specialists, which means that you take some of your allocated funding and you decide that this is a necessary service and we're going to pay a psychiatrist to come for X number of hours, however many times a month, right? So there are 2 psychiatrists associated with the Niagara North Family Health Team. That's it. And neither of them are full-time by any means. I think about a half a day a week each, on average.
There are so many people with mental illness. It can't possibly serve them.
No, and it doesn't. So it means that not everybody in a family health team is going to see that psychiatrist. And sometimes they're still accessing psychiatry services out of the hospital or in other ways. The social workers are really carrying the brunt of the load in terms of counseling. Psychiatrists just simply don't have the time to do counseling. Their role really is in managing medications. And they're really a consultation service now, which means that you would go to see a psychiatrist once, to have a whole assessment, receive a diagnosis, recommendations on medication treatment, and then that consultation goes back to your family doctor, who is usually the one in charge of implementing the recommendations and managing the long-term care of that patient. So psychiatry services have really gone down to pure consultation and not an ongoing care, just out of necessity, because they're overwhelmed and there's no funding.
Well, part of the problem is more proximate, that there are fewer people going into psychiatry. Yeah. I mean, it's the same problem that family practice had 15 years ago, 20 years ago.
Yeah, and because it's underfunded.
Yeah, it's underfunded.
Yeah.
Yes.
How are the family health teams connected into the regional health teams?
Oh.
Are you referring by regional health teams? You mean more into the health systems? Yeah. Okay. Great question. Excellent question. I love it. Long story. That predates even me. It used to be that family physicians really formed a community around community-based hospitals, right? And when we talked about family health teams, we were also talking about the hospital system. With the loss of the community hospitals and the formation of the larger centralized hospital systems, family doctors have been, by and large, for the most part, pushed out. They're in the periphery for primary health care, but what would otherwise have been family medicine, so that primary healthcare portion inside the hospital, is now managed by the hospital system with physicians called hospitalists and sometimes internal medicine specialists. So and the family medicines are by and large removed from the hospital system, and the collaboration and the communication unfortunately has been poor. In some cases, you're right, zero. There's a transfer of records, but the communication is very, very poor. 100% weakness of the current system. There is an opportunity to improve that with the Ontario health teams that are being developed. Fingers crossed. The health teams have not, unfortunately, been well thought out, and there's not a lot of guidance in terms of how to do them. But health teams as a concept is not new and exists worldwide, and everywhere that there are successful health teams, primary care is always at the core of them, helping to manage that system. What remains to be seen is whether in Ontario health teams is whether that is actually able to happen and will happen. In areas where family health teams are pretty well established, many family health teams are taking the lead on that and able to represent primary care and have a strong voice at the table in the formation of those Ontario health teams. In cases where primary care does not have a strong voice, and there are areas of that in Niagara region for sure, it's very difficult for primary care to be able to organize itself now outside of the hospital system to actually speak with a loud enough voice to form a real compelling influence within the formation of the Ontario health teams, and I have real concerns about that, about how that will all play out. So it's interesting times. There's lots to talk about around Ontario health teams. I think that's one of the main potential benefits of heading this direction. It's organized chaos right now, but sometimes there's a lot of people working very hard, lots of overtime, lots of volunteer hours to try to make sure that we see something good and progressive out of the reformation that's happening right now.
Yes.
I have a question. When you're admitted to the hospital, it is really up to you to say, please send my information to my family practitioner, to my specialist for this or to that one. And you can do that, but I don't think the patients know that. And that's why the communication is so bad.
It's what should be happening is they should be asked every time you're admitted to hospital or triage to hospital to ask, which is good. That's not going to change, and it will never happen automatically because the patient always has the right to privacy, and that's privacy from anybody, including their primary care physician. There are situations where a patient may not want their family physician, for whatever reason, good or bad, to know why they're in hospital, and so it's a great question, but it's the obligation then is on the hospital to make sure that they have confirmed with the patient that they are allowed to send those records on, otherwise they can't. So it's always going to be, there's always going to be this having to recheck every time, just out of respect for patient privacy.
One more question. Okay.
Could you please just really briefly give an overview of what 24/7 care means in Niagara-on-the-Lake?
Yes. I will be honest with you, I'm not 100% sure how the physicians here have structured their after-hours clinics and what their criteria are and cutoffs. I practice at a St. Catharines, so that's where I know best.
Describe what you know.
Okay.
St. Catharines.
Okay, well, so in St. Catharines, we have clinics at 5 o'clock every weekday, and clinics every 2 o'clock on Saturday and Sunday. So there are after-hours clinics every day of the week. We have a policy as part of our team that we will stay until all the patients who feel they need to be seen have been seen. We ask that those appointments are booked same day only, so that doesn't mean people are just booking their routine medication follow-ups for those visits. We ask that they are for acute issues, so things that come on, you're sick, something bad has happened, and you need to be checked out right away. So they're for things that need to be seen within 24 hours, and we'll stay till the last patient is seen. After the clinic closes, which could be any time during weekdays, any time from 8 o'clock till 10 or later, depending on how many patients need to be seen, that physician is still on call. All messages are forwarded to an answering service, and if a patient calls into that answering service and feels that they have a medical question or an issue that can't wait until morning, then that call can be forwarded on to the family physician for advice, essentially. To be realistic though, without an open clinic, if somebody's getting a call in the middle of the night, it's usually to answer a question, is this something that needs to go to the ER, or can it wait till tomorrow morning when my family doctor is open? Especially with the limitations on house calls and things like that, we're just not gonna see anything else come back. I think, so it's for urgent medical advice, and as to whether to go to the ER for assessment or not. Does that answer your question?
Well, it does, well, the clinics are open, but from that point until the office hours at 9 in the morning, we're not.
Yeah, well, if in the event of an emergency, so say for instance you call through and you're forwarded to the physician, and the physician says, yep, this is something that needs to be seen, then you're heading down to the ER for assessment. If it's something that could wait until the next day, then urgent communication could go to the family doctor to notify them so that you can be arranged, an appointment can be arranged the next day. Now, keep in mind too, the wait times at the ER, right?
I've already heard about those.
Well, yeah, right. So I mean, when you're thinking about what's appropriate within our given healthcare system, right, where people are not funded to be on call overnight and running clinics overnight, it's just not there. Then if you go to realistically you go to the ER, you're going to be seen about 8 hours later. If you're calling your family physician at 2 o'clock in the morning, and they can see you first, or somebody can see you first thing in the morning, outside of the hospital system, I mean, that's a win in my mind, in the sense that you're avoiding an emergency department to visit, which costs $750 to $1,000 to healthcare system every time you go, and you're getting into a clinic in the same kind of time frame. So this is not a perfect system. I'm not arguing that, but it's within the financial constraints that we're given, and what the evidence has shown is that the effectiveness of the system that we're given is equally as effective, if not in some cases more so, than what happens in the United States under a private healthcare system. So in terms of looking at health outcomes, we actually do quite well.
I'm sorry, I would hate to compare our healthcare to American healthcare.
Oh, I know, we compare everything to
It's not a
system.
comparison.
Yeah.
It's unfair.
Okay. Yeah, I think it's data game is nuanced, but I would say those are some of the broad considerations to think about. That's how. Does that answer your question about how it works with the?
Kind of. I have one more to follow through for the 24/7. Is there actually an ambulance dedicated to Niagara-on-the-Lake?
Oh, yeah.
Oh, yeah.
There are 4 of them. There are 4 of them.
We see them.
Yeah.
That's where they park. A good time to call is not 7 a.m. because that's when the coffee shop opens. And the firemen are there and the policemen are there, and so are the ambulance people. So listen, I'm going to call it a day right now, but this has been, Jordan and the students, it's been a remarkable session actually. The second half especially. I think because the first half told us what the system does or how it's formatted, set up. But the second half we dealt with our experiences with the system and the kinds of things that were problems that we've run into. And Dr. Lukens has been magnificent here. He has a lot of experience in this and very forthright. And he's led this magnificent group of 4, Michelle and Hannah and George and Yazad. They did a great job in June, and they did a great job today. So I want to thank all 5.